Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome to Easy Medical by Dr. Lara. Kindly like, share and subscribe the channel for more informative videos. So today our topic is clubfoot, also called as Talipes equinovarus. In this lecture we will study what is clubfoot, deformities, epidemiology, etiology, risk factor, classification and management. So let us start our lecture from what is clubfoot? So clubfoot is the commonest of deformity occurring at the level of ankle, subtaloid and mid-tarsal joint. Subtaloid joint is a joint between talus and calcaneum, and it is the major joint involved in the eversion and inversion of the ankle. So in clubfoot, the foot is basically twisted downward and inward, and the calf muscles of the affected leg are tighter and shorter than the normal leg. The child also have the weak peroneus muscles. Peroneus muscles are those muscles which are mainly involved in ankle stabilization. When these muscles are weak, there is a great chance of ankle instability and ankle sprain. Then Achilles tendon is also shortened. It is a tendon that connects your lower leg with the foot. Due to the shortness of Achilles tendon, the foot of a child is rotated inward. This condition may be unilateral or bilateral. There are four basic clinical components of the deformities which we can learn through the word cave, C-A-V-E, where C is cavus, which means increased medial arch at midfoot, A is adduction of the forefoot, V refer as varus at the hindfoot, E means equinus, means foot fixed in the plantar flexion at ankle joint. Soft tissues on the medial side of foot are underdeveloped, and calf and peroneal muscles are also underdeveloped and weak, which we have discussed earlier. Now let us discuss the epidemiology. So incidence is 1 to 2 per 1,000 live births, 2% incidence in first degree relations like parents, siblings and children, and 0.6% incidence in the second degree relations like grandparents and grandchildren's, uncle, aunt, nephew and niece. So more than 50% of the cases are bilateral, means both of the foot are affected, and in case of unilateral there is a high risk of right foot being more involved as compared to the left one, and it is twice common in males than females. Etiology. So approximately 80% of the cases are idiopathic, where the underlying cause is not known. There are other intrinsic and extrinsic factors as well. The intrinsic factors involve chromosomal abnormalities like genetic mutation. There is a condition called as trisomy 18, where there are 3 copies of chromosome 18 that also results in a condition called as clubfoot. Other is connective tissue. There may be any connective tissue defect as well. For example, arthrogryposis. It is a condition that involves contractures of more than 3 joints in the body, and there is permanent stiffness present in the body as well. Other factors include neurological factor. There is a condition called the spina bifida, where the spinal cord is out of the vertebral column because the vertebral column is not properly fused. Other intrinsic factors involve any kind of muscular defects, muscular weaknesses, and there may be skeletal dysplasia like any problem in the connective tissue or bone growth. Extrinsic factors involve tetragenic agents, oligohydramnios, a condition where there is not enough amniotic fluid that affects the movement of a fetus in a womb, due to which a child may be present with a clubfoot. Moreover, the extrinsic factors also involve the congenital constriction rings. This condition is also called as amniotic band syndrome, where intrauterine band and rings are formed at the distal extremities, especially the toe and the fingers. The risk factors involve the positive family history, smoking during pregnancy, getting infection during pregnancy, and not enough amniotic fluid, a condition also called as oligohydramnios. Now let us discuss the classifications based on etiology. Number 1 is positional clubfoot. This is due to the abnormal positioning of fetus in the womb. It can be corrected through gentle manipulation and stretches. With early intervention, most of the cases can completely recover. Second is congenital clubfoot, and it is most common type. There are two categories in congenital clubfoot: isolated and non-isolated. Isolated is where there is no other medical condition present except the clubfoot, and non-isolated is where there is some other medical conditions also involved, like spina bifida, and management is based on casting and bracing. Next is syndromic clubfoot, which is due to genetic disorders, example trisomy 18, as we have discussed. Now let us discuss that how can we manage a child having a clubfoot. Number 1 is stretching and casting, also called as the Ponseti method. This is the safer and more efficient method. In Ponseti method, first, there is a little incision done at the Achilles tendon called as Achilles tenotomy. Then for 3 to 4 weeks, a child has to wear a cast. After 3 to 4 weeks, the child must wear a brace for the next 2 to 3 months, and then boards and bar for the next few years. This is a whole procedure followed in Ponseti method. The second method used is called as stretching and taping, also called as French method. This approach also called as functional method because the foot moves on the daily basis and then hold it with the adhesive tapes. After 2 months, the treatment is cut down to 3 weeks until the baby is 6 months old. So once the shape of the foot is corrected and there we gain the normal alignment of the foot, we use night splint until the baby is of the walking age. This method requires much greater time as compared to the Ponseti method. The last option we have is surgery, also called as tendon repositioning surgery. So in some cases where the clubfoot is severe, surgery is recommended. An orthopedic surgeon lengthen the tendon and bring the foot into the normal position and better position. After surgery, the child has to wear cast for 2 months and then a brace for a year. And sometimes there are some children which may not recover fully after the surgery, but they'll be able to do their activities related to the foot, such as standing, sitting, jumping, playing, and all other foot related activities. This surgery is usually done at the age of 9 to 12 months of age. Before this age, this surgery cannot be performed. Thank you so much for watching. Like, share and subscribe Easy Medical.